Hello, welcome ladies and gentlemen to today's tutorial. Today we are going to learn about the thyroid gland. And the thyroid gland, yes, roughly weigh about 25 to 30 grams. It is butterfly shaped or roughly A-shaped structure, which is found in the anterior aspect of the neck, actually the visceral compartment of the neck. Now in the visceral compartment of the neck, we don't have only the thyroid gland, but it will be there with the trachea, with the larynx, with the esophagus, as well as the pharynx. Now these structures, yes, which are found in the visceral compartment of the neck, this visceral compartment of the neck will be bounded by what we call the pretracheal fascia. Now this thyroid gland, yes, is the first endocrine gland to begin development in the human body. Actually in the 3rd week of intrauterine life, specifically 21st day of intrauterine life. Now this gland, yes, will begin around the base of the tongue, yes, where we have the foramen cecum, and then will begin its journey all the way into the anterior compartment of the neck, and to go through a duct which we call the thyroglossal duct. Now usually by the 7th week of intrauterine life, it would have reached its final destination in the neck, which is related to the C5 T1 vertebral levels. And what happens is that, yes, by week 10 we expect that this thyroglossal duct will get regressed, it will get removed actually, so that there is no direct link between them. Now, well, in some individuals, yes, this thyroglossal duct will persist, and it will lead to what we call fistula, or cysts will actually form there. So that's actually the thyroid gland that you have to know. Now, this thyroid gland, yes, will be important. As we said, it is an endocrine gland. As we talked about it, development. Now, remember that with this organ, it's going to have two loops. It's going to have what we call left and right loops, which will be connected in the midline by what we call an isthmus. But developmentally, it's going to begin, to arise from what we call the primitive pharynx, as well as the nuclear crest cells, the so-called fourth layer, of the embryonic, tissue or embryonic, layers. So that is one thing that we are going to find. Now, again, what we find is that, yes, the epithelial lining of this thyroid gland, yes, is going to be simple cuboidal epithelial tissue. But one thing is that, yes, if it is actively secreting its hormones, which we are going to see T3 and T4, then what will happen is that, yes, it can even go to the extent of becoming columnar. Now if it is inactive, then it can be in the form of simple squamous epithelial tissue. So that is one thing that we are going to find with the thyroid gland. Now this thyroid gland, yes, as we said, is going to produce these two main hormones, being thyroxine, that's tetraiodothyronine, or that's the T4, and then of course triiodothyronine, that's the T3. But remember that, yes, in the thyroid gland, yes, it's actually going to produce a lot of these T4 ones. About 90% will be coming from thyroid gland, mainly producing the T4. Thyroxine will be produced mainly at the expense of triiodothyronine. Just about 10% will be produced in the thyroid gland. But the biologically active form of these thyroid hormones will be actually the T3, triiodothyronine, and they will be activated from thyroxine, actually in the peripheral tissues, mainly in the liver. So in the liver, tetraiodothyronine or thyroxine will actually be converted to what we call triiodothyronine to be biologically active. Now these hormones are going to regulate what we call the basal metabolic rate of the body. Now one thing is that, yes, these epithelial cells, these one, they will be forming what we call follicles. Now it's estimated that in the human thyroid gland we have about 300 million follicles actually in there, and then the epithelial cells, which will be cuboidal in actively secreting, and they could actually be elongate to become columnar cells actually. Yes, they will surround what we call the colloid, which is the fluid in between these follicular cells, so that, yes, they will produce what we call what you call thyroglobulin. Now thyroglobulin will be the inactive form or the pro hormone for what we call the tetraiodothyronine, that is thyroxine, and triiodothyronine. But remember that this triiodothyronine and triiodothyronine will actually be produced from tyrosine amino acid and iodine. Now, if we have one molecule of this tyrosine and combined with what we call a molecule of what we call iodine, then we are going to have monoiodotyrosine. Now, if you are having two of the iodine to tyrosine, then you are going to have diiodotyrosine. So that if we have diiodotyrosine, two molecules to combine, then we are going to have tetraiodotyrosine, that's a thyroxine. But if we are having one monoiodotyrosine and one diiodotyrosine, then we are going to have triiodotyrosine, giving us T3 triiodotyrosine, thyronine actually. So these are the things that we have to actually understand with regards to this thyroid gland. I said that this thyroid gland is going to have two main loops, left and right loops, connected at the central region by an isthmus. But what will happen is that there could be a third loop, which we call it pyramidal loop, and this pyramidal loop will actually extend from where we have the superior portion of the isthmus all the way to actually the thyroid cartilage, the region of the thyroid cartilage. So without much ado, yes, let's look at this thyroid gland that we have briefly, and we end it there. Right, so we said that in the anterior neck we are going to have this thyroid gland. Okay, as you see here, there's a thyroid gland. Now for you to see the full extent, okay, this is the thyroid gland. And this thyroid gland, yes, we're saying is butterfly shaped or H-shaped. This, okay, because this is to the right, this is the right loop, this is the left loop, and they'll be connected in the midline by what we call an isthmus. It's also going to span from what we call C5 vertebral level all the way to T1 vertebral level. Actually, yes, it will actually surround the area. Okay, to be, around the area where we have the cricoid. It will cover around where we have the cricoid cartilage, as well as yes, the proximal portion of what we call the tracheal rings. The superior portion of the tracheal rings. It will be related to it in that regard. Now, as I said that it's going to develop at the base of the tongue, yes, near this area where we have the foramen cecum, okay, and then it will run all the way to reach its final destination through what we call the thyroglossal duct. Okay, so by week 10 this thyroglossal duct should have been regressed, because by week 7 the gland would have reached its final destination, so that if it gets regressed, then it's gone. But if it persists, which in some people we have such a phenomenon, then it is going to lead to what we call fistula. There will be that kind of connection between, of course, the oral cavity by way of the foramen cecum and the thyroid gland. So as I said, we're going to have the left loop, and then of course a right loop will be present, and then connected at the midline will be the isthmus. Now sometimes in some people, yes, in about 50% of individuals, projecting from the isthmus to yes the area where we have the thyroid cartilage will be what we call the pyramidal loop. So that is one thing that we are going to actually find. Now this one will actually be producing what we call the thyroid hormones, okay, the T3 and T4, yes. But in addition, yes, by way of development, there could be another cells, which we call them the parafollicular cells, or the so-called C or clear cells. Now remember C for calcium, so they will be regulating what we call calcium metabolism. So they will be, the parafollicular cells will produce what we call calcitonin. Now this hormone calcitonin will be important, yes, in actually reducing the blood calcium levels. Now these parafollicular cells will actually arise embryonically from what we call the ultimobranchial bodies. Now once I talk about calcitonin, then posterior to this gland, okay, behind, so over here and then here posteriorly, and then on either side, we are going to have 4 glands, which we call them parathyroid glands. Now these parathyroid glands will be producing what we call parathyroid hormone. So parathyroid hormone will be important in actually antagonizing the effect of calcitonin. So while calcitonin is reducing blood calcium level, parathyroid hormones is performing all those activities which is going to help raise blood calcium level. So that is one thing that we are going to find actually with the thyroid gland. But one thing is that yes, this thyroid gland producing these thyroid hormones, mainly T3 and T4, won't do it in isolation. They will have to be regulated, so by what we call the anterior pituitary gland secreting what we call the thyroid stimulating hormone to influence the secretion of the thyroid gland. Okay, thyroid gland. Now one thing is that yes, from the anterior pituitary, what will happen is that yes, thyroid stimulating hormone will be released, will be secreted. But this secretion is also influenced by what we call thyrotropin releasing hormone coming from the hypothalamus. Okay, hypothalamus. So that yes, the thyrotropin releasing hormone is actually controlling the secretion of thyroid stimulating hormone, which is also controlling the secretion by the thyroid gland, forming that kind of axis by way of controlling their secretions. So that is one thing that we are going to find. Now we are saying that now there will be some situation where this thyroid gland yes can become enlarged in situations where we have goiter, endemic goiter for instance, where because perhaps in the community they are not taking in iodine containing food, then the thyroid gland becomes enlarged. And what's the reason? The reason is that because the thyroid gland is failing to produce a lot of these thyroid hormones, yes, the body thinks that the body continues to the anterior pituitary continuously secrete what we call thyroid stimulating hormone, and therefore it stimulates the thyroid cells to actually enlarge, go through hypertrophy and of course hyperplasia, and then becoming enlarged in that regard. Now again, if you take in foods which are rich in what we call goitrogens, like millet, like cassava, cabbage, broccoli. Yes, we have a whole list of foods which contain what we call goitrogens, which inhibit the uptake of iodine by the thyroid gland in making what we call thyroid hormones T3 and T4. In such a situation, the patient may also present with what we call enlarged thyroid gland, which is goiter. Okay, which is goiter. So that is one thing that we have to know about this. Now this thyroid gland, we said, is going to regulate the basal metabolic rate, how you metabolize the food that you take in, so that usually if there could be a situation where we have hypothyroidism, where the thyroid gland is working at a very low pace or making it thyroid hormones, the hormones that it's producing that are low place. And then we could also have what we call hyperthyroidism, where it begins to actively perform its role excessively. And such a situation, yes, we also have what we call the Hashimoto's thyroiditis, Graves' disease and what have you. So all those ones can also happen as part of the disorders that we find with the thyroid gland. Now with this, as we end with actually, yes, we also have to learn about what we call the relations that the thyroid gland has with other structures, in the neck area. So with the relations, we have what we call the anterolateral relations. There's anterior aspect. So anterolateral relations, it will be related to what we call, the stenothyroid, muscle. Stenothyroid muscle. There's stenothyroid muscle. Then of course stenohyoid muscle, as well as you have the superior belly of the omohyoid muscle. Okay, will be related to it anterolaterally. Then for posterolateral relations, okay, so for posterolateral relations, okay, so this posterolateral relations, it will be related to what we call the carotid sheath. So remember that the carotid sheath, yes, will also contain around this area, because there's it, okay, the carotid sheath. Okay, there's the thyroid gland. So the carotid sheath will encircle, will cover these structures where we have the common carotid artery, Yes, we also have what we call the internal jugular vein, as well as the vagus nerve, the cranial nerve 10, who actually be related to it, posterolaterally. Then for posteromedial, posteromedially, it will be related to what we call the larynx. The larynx will relate to it posteromedially. Apart from the larynx, yes, even the trachea. The trachea rings will also relate to it posteromedially. Yes, of course, the esophagus. Apart from the esophagus, the external laryngeal nerve, as well as the recurrent laryngeal nerve posteromedially. Now, one thing that is very important when we mention the posteromedial relations is the recurrent laryngeal nerve. Now, the recurrent laryngeal nerve, yes, as we know, hooks around actually the left recurrent laryngeal nerve hooks around the arch of the aorta. Then with the right recurrent laryngeal nerve hooking around the right subclavian artery, and then they will travel through the through the tracheoesophageal groove to actually supply what we call the muscles of the larynx. Therefore, in situations where, let's say, you are going to perform thyroidectomy, you want to remove the thyroid gland, then care must be taken so that you don't injure this recurrent laryngeal nerve. All right, so that is one thing that we have to actually take notice whenever we are talking about this. Now, with respect to blood supply, yes, this gland is actually richly supplied with blood. Why? Because this is an endocrine gland, it is ductless, and therefore all its secretion will have to be diffused, get diffused into what we call surrounding blood vessels, capillaries, to be taken into systemic circulation to target cells. So it is supplied by one of the the first branch coming from the external carotid artery, being what we call the superior laryngeal artery. This artery. Yes, there is another one which is actually coming from what we call the subclavian artery. Actually, another one coming from the subclavian artery, and that one is known as inferior laryngeal artery. Now, so that is how this supply is going to be. Now remember that the superior laryngeal artery will be in association with what we call the external branch of the superior laryngeal nerve. So it will move with the external branch of the superior laryngeal nerve. That's what we will find. Then of course, when we talk about the inferior thyroid artery, then it will be related to what we call the recurrent laryngeal nerve. So recurrent laryngeal nerve will run alongside what we call the inferior thyroid artery. Now there could be in some individuals another third blood supply which will actually arise from what we call the thyroid, which actually arise from what we call the brachiocephalic trunk, which is one of the divisions of what we call the arch of aorta, brachiocephalic trunk, or maybe arise directly from the arch of aorta, yes, directly, or even come from the common carotid artery or the subclavian artery, and that artery is known as thyroidea artery. So for thyroidea artery, yes, it will arise all the way, and then to come and then of course supply the area of the thyroid over here. That is the isthmic area. So the isthmus, which is the narrowest part over here, will be supplied, the anterior portion will be supplied by what we call the thyroidea artery. Yes, in about 10% of cases we are going to find this variation. Now, if the thyroidea artery is there, so running this way, so it tells you that it's going to run, yes, along the anterior aspect of the rings of thyroid, the trachea. If that is the case, then if we are going to perform tracheotomy, actually, if you want to remove any of the tracheal rings, tracheotomy, then what will happen is that care must be taken so that you don't cause injury to this thyroidea artery. If so, then it's going to result in a lot of bleeding, profuse bleeding. So that is one thing that we have to actually appreciate over here. Now, with respect to venous drainage, by way of veins, then what will happen is that it's going to be drained by three veins. Actually, it's going to have what we call superior thyroid vein, it's going to have middle thyroid vein, and of course inferior thyroid vein. Now remember that the superior and middle thyroid veins will be drained into what we call the internal jugular vein. So they will be drained actually into the internal jugular vein. The superior and middle thyroid veins will drain into the internal jugular vein, and then of course the inferior thyroid vein will drain directly into what we call the brachiocephalic vein. So there will be brachiocephalic vein, but of course that the internal jugular vein will eventually drain into what we call the brachiocephalic vein. Then of course by way of lymphatics, what will happen is that we have initially they will drain into what we call peri. Peri means around, thyroid lymph nodes. Then eventually we'll go into what we call the pre-laryngeal, then of course into what we call pretracheal, then paratracheal lymph nodes eventually. But of course on the lateral aspect, laterally they will actually drain into what we call superior inferior deep cervical nose, So mainly that is how it's going to be drained. All right, so this was just a quick tutorial trying to explain briefly what the thyroid gland is. And remember that the thyroid gland is going to be important as far as regulating your basal metabolic rate is concerned. All right, may God richly bless you.